We'll move on to the next panel discussion. It will be moderated by Dr. Ravi Mohanka. The topic for the session is liver transplant, what every gastroenterologist should know. Our panelists will be Dr. Chetan Kantharia, Dr. Gaurav Gupta, Dr. Amit Gupte, Dr. Mihir Vora, Dr. Prashant Kadam, and Dr. Vijay Dhakre.
Thank you very much. So while we wait for all the panelists, so this is a very basic discussion, panel discussion, where we find that a lot of times when we're doing transplants and our colleagues, gastroenterology colleagues are taking care of these patients, sometimes there is a little disconnect. So just to bridge that gap. So that's the expert panel. I think Dr. Kantharia is not there. So the first question is, when we do a evaluation of a liver transplant patient, what are the questions that we are trying to answer to know whether we should do it or not? So, Dr. Mihir, can you take up some of the first three questions?
Sir, MELD score, child score, organ failures, HCC, portal vein thrombosis, quality of life. So these would be like 4 or 5 indications which I would consider from patient's perspective, that whether we should think about the severity of disease and transplant. And etiology would be like for a decompensated chronic liver disease, multiple etiologies which you have, acute liver failure, the causes for the same, where they need liver transplant and for which evaluation should be done.
And Gaurav, surgically, what are you looking for when you're doing an evaluation of a patient? Are there things that will make a transplant more difficult or easy? What are you looking for?
So surgically, we will always look. We'll start from patient has gone any previous upper abdominal surgery, so you expect a lot of additions. Now, a lot of things are involved in perioperative risks. We have to look at whether there is a portal vein thrombus or not. If there is a portal vein thrombus, what is the extent of the thrombus? What kind of the collaterals are there? Whether we need to go, whether we might have to some ligate those shunts. Need to see what kind of the organ you are taking, whether we are taking a small GRWR, need to change some things. So these are some of the surgical planning which we have to do, what kind of reconstructions we have to do on the bench or in drop. So that all we have planned before we go ahead with any transplant.
So based on this evaluation, you'll get a good idea of what is the likelihood of a successful transplant and what are the risks that you have to discuss with the patient and for them to accept it. So the general contraindications are all known to us, active, uncorrected malignancies, infections, and so on and so forth, which will obviously be a contraindication. But although all of us are familiar with what are the indications for transplant in all these categories, what are some of the contraindications that you will not offer transplant to these patients? Why don't I have Amit comment on this?
So one thing is whether the patient has complications of cirrhosis and whether there is any reversibility expected in the patient's condition, then we may hold and observe the patient. But otherwise, as you have pointed out here, if ALF is because of AKT-induced hepatitis, then that's not a contraindication for transplanting ALFs. In HCC, portal vein tumor thrombosis is definitely a contraindication. We can consider them for transplant after downstaging once the PVTT has completely gone away.
So in any of the etiologies, if the liver transplant is going to fix the problem, the complication, then you're okay to go ahead. But if it's not going to fix the problem or the risk of recurrence is too high, then it's not a good idea to do it. Now, often we face this question and patients ask us whether we should do a living donor or a diseased donor transplant. Now, that's a question in India, more pertinent in India, because we do almost 80% of transplants in India are living donor transplants, and the waiting time for a diseased donor transplant could be months to years. And we have a reasonably high risk of mortality on the waiting list. So in which scenarios would you prefer a living donor transplant over a diseased donor and vice versa? Let's have all of you go quickly one by one, starting with Gaurav.
So I think unfortunately, as Dr. Ravi says, we have 80% of transplant living donors, so we don't have an option. So if there is an adequate donors, you would like to transplant everyone given a cadaver organs, but that practically not possible. So any sick patient and acute ACLF patients, ALF patients, Now we can't, there is a long waiting list, so we can't keep them on the list for too long, and we'll have a waiting list mortality of more than 50%. So we are forced to do a living donor liver transplant. Now there are certain situations where you will probably will wait for the cadaver, like a very big person, like 150 kgs, where you can't have a, the donor is not available or dual lobe or, option is not available. Then you would like to wait for DDLT. Extensive PVT, you will probably, it's not that decompensated, you would like to do a cadaver transplant in those situations. So these are some of the things, but most of the times we don't have an option of waiting for a diseased donor. So you're forced to do a living donor transplant.
So in certain situations, like let's say ABO incompatible or HCCs who are on immunotherapy, what do you think, Prashant? I mean, does a living donor transplant give you more leeway to time it better?
Yes, I think that would be a proper bridging therapy for transplantation in these patients, and then of course we can wait for a whole liver graft for these patients. Obviously, because of the shortage of organ donors and organs in our country, we have to rely a lot on these bridging therapies and wait for the graft to come to these patients.
Great, thank you. So, Mihir, what's the standard living donor transplant criteria for a donor to be eligible for being a donor? What should a gastroenterologist know before they send you the patient as to who can be a donor in the family?
So every center will have few basic rules, but the cutoffs will vary from center to center. But the first point is somebody should age between 18 and 50 to 55. BMI should be close to 30. There is no sacrosanct number as 30, but you want donor to be safe. So a complete thorough evaluation that they should not have any issues. Whatever issues are there can be solvable. They have to be family members. We have done their viral marker screening. They should be okay. The volume should be adequate. We try to achieve a GRWR close to 0.8. We can come down, but every case-to-case basis will take that into account. We would see their MRCPs. We will do their cardiac screening, their pulmonary screening, nutritional assessment, and based on that, we'll take a call. So this would be a rough assessment, how a donor workup should be done, and then we proceed from there.
So unlike most countries, in India, it's almost always the family members are the only ones who can donate. It's altruistic donation is pretty rare, just because there is a lot of regulations that are attached with it. The other thing that a lot of our gastroenterology colleagues are unfamiliar with is how a diseased donor liver is distributed. And while there is an emergency listing for super urgent listing for patients who have acute liver failure or primary non-function and such, and there is in-house donation, if there is an in-house donation in transplant center, then you get priority. But how is the liver allocation different in the various states in India? Because health is a state subject in India, so every state makes its own allocation sort of rules and policies. So Vijay, would you like to comment on that?
According to, in Maharashtra, we have 4 zones. So according to the zone, the organ gets distributed. The first preference goes to the super urgent listing, pediatric patient. If there is no pediatric patient in super urgent, it goes to adult super urgent. And if there is no adult super urgent, then it goes to the in-house or the in-house patient list. And then if there is no available or suitable recipient in the in-house list, it goes to the city list or the zone list, and then accordingly so on the list or the donor organ gets distributed accordingly.
So in the past, there used to be a preference for residents of a certain state to get preference in that state, but it's no longer true. Now, any patient from anywhere in India can register in any part of the any state actually. Now, this is very important because the organ donation rates and transplant rates are very highly variable across India. So there are only 5 states who have the highest number of organ donation. Those are listed on the that side. But the number of transplants that are done are highest in Delhi or Delhi NCR, although the number of donations there are few. So this affects this geographic inequality. It really affects patients who reside in areas where there is poor organ donation rates. So to account for that, every state has a different policy for how organs will be allocated. And as a gastroenterologist, each of us need to know, because a patient with high MELD, you should probably prefer listing in a place where the allocation is based on MELD score. Whereas a stable patient may go to another state where it's not based on MELD score, maybe it's based on the date of registration. So Prashant, would you like to talk about this a little?
Sorry, I didn't catch your question, Dr.
So
Mohanka.
the question is, how is organ allocation, liver allocation policies different in different states?
Well, if we go by MELD, now within MELD itself, there are many discrepancies in which females are disadvantaged in MELD. Patients with high creatinine will go up on the MELD. So patients, states which have got MELD criteria, their patients would be quite disadvantaged compared to states which don't have MELD. Compared to states which have just CTP criteria or other criteria.
So in addition to transplant centers, we have what is called as NTORCs, non-transplant organ retrieval centers, and organs that are donated from such centers go to a common pool and then they are distributed across all transplant centers. And then there is standard criteria, extended criteria, and DCD. We currently do not do DCDs in India commonly. It's done really rarely. But what a lot of us don't know is what kind of organs our patients are getting. So the gastroenterologist and the transplant team have to talk to each other to make sure that this organ is appropriate for this patient, and a very stable patient should maybe not be offered a very high risk extended criteria organ. And then obviously we are aware of what organs should not be accepted at all, and those organs, if they are being offered to our patients, we should basically decline. We are all familiar with early complications, and Gaurav, would you like to talk about some of these complications and how they can be, serious or non-serious in the first early period?
So actually the surgical complication have gone down drastically in last 10-15 years. And the two things which we are really afraid are, first is the primary non-function, which is very, very rare in a living donor. Even in a cadaver transplant, risk rate is just 1 to 2%. Other dreaded complication is hepatic artery thrombosis. That is also, the risk rate is around 1% or less than 1%. Now, except these, the rest of the complications like portal vein thrombus, IVC stenosis, these are very rare and practically does not happen. We may see one patient in 200 transplant, 150 transplant. The other problem which may happen in especially in our setting is the biliary complication. The risk is little bit higher in the living donor setting up as compared to the cadaver. And these are the only surgical complication which happens. In rejections, again, we don't see patient dying from the rejection. Infection is the one thing which we are worried about in the era of multi-drug resistant infections. And that too generally happens within the first 4 to 6 weeks of the transplant. That is the time if someone happens a MDT bug, then you are afraid of those patients. Otherwise, most of the patients do very well after transplants with very few surgical complications.
So, so we do get some late graft complications, surgical complications, but they're easy to manage. They're all fixable. Very rarely they're life-threatening or serious. But we do struggle with long-term outcomes. And those are the real problems that liver transplantation is facing now. Although we have excellent short-term outcomes, in the long term, they have the same metabolic complication, the same problems that other transplant patients face. And that is where we need the help of a good gastroenterologist colleague, because we would like them to take over and the care of these patients in the long term. So just in the interest of time, I'm going to say, and they should be familiar with the immunosuppressive medicines that we use and their interactions with other drugs that are out there. So in summary, I think although a transplant has been like heavily surgically dominated field in the past, but in interest of long-term outcomes, it's best that we do jointly manage these patients, because the real problems we are facing now are long-term metabolic systemic problems where we surgeons are not really good at managing. So we would encourage and like more of our gastroenterology colleagues to manage these patients in the long term and just be familiar with immunosuppressive drugs and the stuff that we use all the time. Thank you very much. Thank you.
Thank you, Dr. Mohanka and the panelists. We are heading to the final panel discussion for the day. It will be moderated by Dr. Ravindra Karanjikar, setting up liver transplant in Tier 2 cities, challenges and opportunities. The panelists for this discussion will be Dr. Mehul Panchal, Dr. Rakesh Jain, Dr. Dharmesh Dhanani, Dr. Dhaval Mangukia, Dr. Prashant M.V., and Dr. Praveen Agarwal.
Hello everybody. I welcome my panelists here. This is a sandwich session between the awards and the main sessions. Probably it is looking at the administrative part of the liver transplants or the kidney transplants and other areas where multiple hospitals are involved, but they cannot start the centers. This has been specially seen at the multiple 2-tier cities and 3-tier cities. In my opinion, India can do far, far better if the transplant centers increase into the 2-tier cities. But there are multiple difficulties which we face. So quickly I will, as the short of time is there, quickly I will run through the various difficulties, various verticals, and let the panelists speak on that. So the first vertical will be lack of infrastructure. So doctor, can you tell me about your experience of setting up? Because I had been responsible for about 6 or 7 liver transplant centers in the country to start. Various centers have various difficulties. And as Dr. Ravi Mohanka just now said, that every state has different rules, different regulations. And from that point of view, to set up a transplant center becomes a very, very difficult thing. So one of the things which 2-tier cities face is the lack of infrastructure. So doctor, can you tell me?
That's actually a problem of a lack of infrastructure, because the practice in India in tier 2 city and tier 3 cities are basically a polyclinics rather than having a good comprehensive hospital. So the most important things, the establishing a good comprehensive hospitals. Second important things, the willingness of a management to go from level 2 or level 3 surgeries to a level 8 or level 10 surgeries. Third and most important thing is the having a ACE on the card. So that means it's not only about having a liver transplant team on board and we start the programs, but it is also about the having a OT infrastructure, whether it's a ICU infrastructure, round the clock intensivist availability, a good state of art laboratory who can able to perform the therapeutic drug monitoring round the clock. Similarly, availability of a good blood bank. These are the most important things. And once we kill this, each and every nail, I think we can make a beautiful art for liver transplants center.
Thank you. The next infrastructure is shortage of trained personnel. So Dr. Dharmesh Dhanani, you can tell me about this. Dharmesh? Yeah.
Specifically in the tier 2 city, for the starting the organ transplant program, two things. We need the good support from the tertiary center team. We with the collaborate with the hospital and doctor team to train the staff from the ground level, like a OT assistant, or the a surgeon, and the intensivist care, and the, if required, the radiology and the histopathologist also. Because the every level collaboration is there. Because the routinely, whatever the setup, routine work is going on for the transplant, some specific extra precaution and the extra training is required. So everybody is not trained. If anybody is trained also, but routine high volume work is not going on that center. So definitely the tertiary center team, which is good collaboration and the training program helpful in that part.
Thank you. Financial constraint is another thing for which the 2-tier cities, say like in Surat we have been seeing it. Ahmedabad it is little less but more in Surat. Surat is about 3 hours away from Mumbai. If the things can be done at Mumbai, why to do it in Surat? Because you are as it is spending 20-25 lakh rupees there. And Surat, Mumbai, even if you come by car, it is few thousand rupees. Come to Mumbai, if somebody is there to stay with you or you can stay with somebody, the whole operation can be done, and then perception is there about Mumbai doctors doing it better. So from that point of view, financially making it viable at a 2-tier city, you will have to go down. When I started the center in Pune about 7-8 years back, the first thing was to slash my rates by about 30 to 40% in Pune to start with, to make a name. And once my name was there, once the center was established, then we could charge probably the similar rates at Mumbai. So these financial constraints are the very important constraints at a two-tier cities. So can Dr. Jain, can you elaborate on Dr. Jain?
जहाँ तक
Dr.
फाइनेंशियल
Akash Jain,
कंसर्न
yeah.
की बात है तो
Yeah, please.
टू टायर शहर में बहुत इजीली चैलेंजिंग है, बहुत सारे डाटा अवेलेबल है और इजीली मैनेज पॉसिबल है। तो मुझे लगता है क्योंकि वहाँ लीवर ट्रांसप्लांट होता नहीं है और जब वहाँ शहर में एक अपॉर्चुनिटी होती है तो बहुत सारे लोग आ गए थे कि हमारे शहर में ये लीवर ट्रांसप्लांट हो रहा है। और टू टायर सिटी में जब लोगों को बाहर जाना पड़ता है उसकी जगह शहर में जब अपॉर्चुनिटी होती है तो मुझे लगता है फाइनल स्टेट एक चैलेंज है, लेकिन वो इजीली मोटिवेट हो जाए। जैसे साहब ने सूरत का बात किया तो सूरत में उसका बहुत बड़ा ग्रोथ हुआ है। तो आज गुजरात बिकम है लीवर ट्रांसप्लांट के लिए जो लोग बहुत ज़्यादा बाहर की शहर में जाते थे, तो फाइनेंशियल कंसेप्ट अभी वो चैलेंज नहीं है मुझे लगता है।
Second important thing, sir, I just like to add.
Yeah.
From the hospital point of view, there is a enough amount of a reserve fund that we have to keep it. We know in the second tier 2 city, the transplant is a cherry on a ice. So to preserve that particular things, the institute has to bleed certain part. Second important things, जैसे sir ने बताया कि बहुत सारे donors and trustees है, they come forward. And the third and most important thing is many times crowdfunding, Chief Minister Relief Fund, Prime Minister Relief Fund, Mayor's funds, they are also contributing up to somewhere around 75% of a transplant cost. So I think that challenge we have in Surat, we have overcome that particular part. Thank you, sir.
Thank you. So next challenge is awareness in your area. People willing to donate, especially the donors. It's a great challenge across the country, not only smaller place, bigger places. So can Dr. Dawal speak on this?
Yeah, of course, the awareness and education in terms of the general public or in a social platform would be needed. At the same time, what we can add on it is it's a transplant or maybe any of this kind of surgery in a particular field of the gastroenterology would be a hand in hand with the gastroenterologist as well as the surgeon. So once you are establishing any program, particularly for the liver transplantation, so although we have discussed regarding the infrastructure, logistic part and skills and everything, but once you do the things, of course, the selection of the patient, education of the donors, in particularly in the field, whenever we are going out with the living related liver transplantation. So that kind of awareness program should be run through this kind of hospitals at the time of establishment only. So that would help the patient as well as the doctors, those who are not particularly a specialist in the field of transplant. So that would be required for both the sides.
15 minutes are given. I'm given 15 minutes, so I can't ask them to stop. Please. The next will be logistic challenges. This is one of the important things. Can Dr. Kamath speak on that? Ms. Kamath. Okay.
The logistic challenges. When we are talking about cadaveric transplant or a live donor transplant, the most important thing is, as we are in the tier 2 city or tier 3 city, we are heavily dependent on the mentors. Second important things, we are also depending on if there is a inter-district or a interstate organ harvesting parts. Right now, the institute is ready, but we are also dependent on many times public transport like Indian Railways or the private charters on the same part. But yes, one's supposed to keep somewhere around 5 to 10 lakhs reserve fund if there is any kind of a good opportunity comes as a part of a logistic challenge. Thank you.
Donor availability is another challenge. Can Prashant talk on this?
See, availability to donors is very difficult nowadays because we need to build a lot of awareness in the patients, also in the donors, starting the social media campaigns or also in the, tying up with the bigger organ donation campaigns, also social media campaigns so that we'll get a lot of donor availability, especially everybody will be ready to donate the organs, but when it comes to the table, nobody will ready to give the organs.
Thank you. I think this being a short session, I will limit my questions to these. But I am very sure that India can be a superpower in terms of transplant, provided we take over two things. One is that the other day I was discussing with Dr. Ravi and other people, is that if the two-tier cities are permitted to do the live liver transplant, without having the full-timers in hepatology or hepatic surgery, then probably the numbers will go up. 100 cities, four in a month or two in a month, probably in a year they will do 100 cases and you will have thousands of cases in the country. And of course the subject which Dr. Ravi Monka has opened up recently also is the circulatory death. If it is accepted, then probably we will have so many cadavers available for this that backlog will be completely washed out. So from that point of view, if the legislative people and the parliament, we will be talking to them also recently now, if it is possible, then the more and more cadavers will be available and the transplant program will be successful in India. So thank you very much. I've finished now. Thank you. 30 seconds early.
Thank you so much. Thank you to all the panelists and the moderator. I now